Hey, welcome everybody to the We Fix Pain podcast. This is episode number 7 with our special guest, Dr. Allie Matthews. She is a sports medicine, primary care sports medicine physician in beautiful scenic San Antonio, Texas, and she is joining us live today. Doc, welcome to the show.
Hi, thank you for having me.
All right, we got some special questions and some special information. I know you're going to help us and drop some knowledge bombs on us. But let's go over your background here. So it looks like you went to osteopathic school in beautiful scenic Parker, Colorado. I've been there multiple times. I love that town. Looks like you did some work at Texas A&M and Bryan, Texas, and did a primary care sports medicine fellowship program at Christus Health Santa Rosa. Doc also is the clinical staff of the San Antonio Rock and Roll Marathon and the assistant medical director, is a team physician for sounds like 2 high school football programs, and she currently works for the Orthopedic Performance Institute with a focus in sports medicine related problems including fractures, sprains, strains, injury prevention, nutrition, running gait analysis, and diagnostic ultrasound. Man, that is a mouthful, Doc.
That is a lot of words.
Well, we're going to break that all down, what that means. I'm glad to have you on the program here. 2 of my favorite specialties to deal with in the medical community is the primary care sports medicine physician and the physiatrist. I feel like you guys do an excellent job of quarterbacking care and playing in the sandbox nicely with all the other healthcare providers. We want to talk to you about that a little bit. But first, let's go over your origin story. How'd you end up in sports medicine? How'd you end up in primary care? And how'd you end up in medicine?
I love that you used origin stories, kind of like a superhero. I never thought of that analogy.
You are a superhero.
I love analogies too. Yeah, my father was a doctor, so I grew up around doctors, and I used to go to his office and pretend help him. So I always had an interest in medicine, and I also always just loved sports growing up. We watched football games. I grew up in Kansas. I played basketball, peaked as an 8th grader. I was
the 8th grade phenom. You were the 8th grade LeBron James.
Yes. Yep. I made JV as a sophomore and then quit because I did swimming in college and got a scholarship for that.
Hey, congrats.
Thank you. Which led me into triathlons, which was really fun. I biked across the country.
Are you serious?
Yeah.
That's awesome.
Before med school from Boston to Santa Barbara. It was awesome. And then in medical school, I needed a way to relieve stress, so I joined a CrossFit box, which was awesome too. And so it was just that mixture of medicine and sports, and those 2 passions that just became one. And I loved residency. I went to a primary care residency at A&M, and their goal is to teach physicians to be well-rounded and do everything, and I loved that appeal, but I just really wanted to hone in on sports and athletes. It's just a great population to take care of.
Yeah, so it sounds like your background kind of led you. You had the interest in it. You found a good niche and a sweet spot, and you said, let's take this one step further. So my question is, you have a traditional 4-year residency, and then on top of that, it's a year extra in sports medicine. Is that how it works for you?
So it was 4 years in medical school, where 2 years in the teaching arena, then 2 years doing clinicals, rotations, and then it actually was a 3-year residency in family medicine. Residencies vary 3 to 5 years, or 7 if you're a neurosurgeon. So 3 years for family practice, and 1 year at doing sports only for fellowship.
Gotcha. I appreciate the origin story here, and that kind of brings us up into a specific time period here. My favorite part of the interview is 5 random questions. So we're going to try to get to know you. I'm not going to reveal anything the FBI would want to know, but let's try to get some fun facts about Doc here for our listeners and for our providers that interact with you. All right, your bucket list trip, what would that be?
Right now, at the moment, I have a lot of them, but Alaska comes to mind because it's so hot right here with the summer, and I've never had a patient go to Alaska and come back and say they had a bad time. It's always these most beautiful scenes and epic outdoor stories. So right now, Alaska.
Yeah, that's what I've heard from same folks. Epic scenery, epic people.
Right.
All right, here we go. Aisle seat or window seat?
Window. I think people who don't appreciate flying like really need to stop and look at life. Like you are in a metal tin can in the air. Look out. Stop putting your windows down so you can watch your screen time. Look out and see how small the world looks and how big and beautiful those clouds are.
Yeah, and the first time that resonated for me, we were flying over the Grand Canyon, and I was like, holy cow. You see the postcards, but when you see it from the air, you're thinking like, Jesus, this is massive.
Yeah. I also have short legs, so I can empathize with people that need the aisle, but I'm not one of them.
Must go to sporting event. The sporting event you want to go to most.
Ooh, is the one that I get to play in. I don't love watching sports as much as I love doing them. So to me, it's more fun to do a pickup game of basketball than go watch the Spurs, even though they're very cool to watch.
Do you still play in a basketball league or any?
No, I would not call it playing in a league. Like I can play horse with my dad on a weekend, but no, I wouldn't call it playing.
All right. Your favorite say what moment in healthcare? And I'll go first to give you a brief second.
Okay.
I had a patient that was coming in and telling me his scrotum was a problem. And I'm going through the diagnostic triage of like hernia, sports hernia, athletic pubalgia. Do I need to do a hernia check? Because it's been a minute. And he's like, you're looking at the wrong area. And I was like, where do you think your scrotum is? And he points to his sacrum.
Oh.
Completely different, but to him, sacrum was scrotum, and so yes, that was my favorite say what moment in healthcare. So that being said, your most interesting say what moment in healthcare?
I don't know. I'm trying to think of one that's appropriate, but also like funny. I'm not a very good joke teller.
G13, right?
I will have to say that I had a patient that was at my age, and this was like 5 years ago, and she was 20 weeks pregnant and didn't know.
Oh wow!
And that's pretty far along to be like, what? But had some nausea, it got away, but she's just had this mass in her belly.
Wow.
So yeah, that would be my say what moment, is just not realizing that you were halfway through your pregnancy.
Yeah, she was growing an alien, just kind of like the movies.
Yes. Little tumor.
Yeah. All right. You got to win a karaoke contest. What's your winning song?
Oh, this depends. Like, what is the parameters for winning? Because I would have to say Alanis Morissette is very fun to sing to, but I'm not sure I would win. Whereas if I did a classic, more like country, I think I could fake the notes better.
Yeah. I'm going a hair band, probably Poison, Nothing But a Good Time.
That sounds fantastic. I'll be there.
So back to the clinical question. We got the fun stuff out of the way. What is a primary care physician? I think most people know what a primary care physician is. What is a primary care sports med physician? I think a lot of people know what a primary care does. It's the person you see for general health and checkups and wellness, and if you get sick. I think people kind of have an idea that sports medicine physicians play with athletes. But what's the hybrid? What is the exact role of a primary care sports med physician?
That's a great question. It is such a new specialty. You have specialties like surgeons and obstetrics that have been around for forever. Primary care sports medicine is relatively new, and it really is this melding of primary care, so pediatrics, family medicine, some internists, and sports medicine taking care of the athlete. So sometimes when I tell people when I'm talking with them briefly on the street is it's non-operative orthopedics. So I don't do surgeries. I will do procedures, but I don't do surgeries. I do lots of injections. I take care of fractures. I take care of tendinitis. I take care of a lot of pain, back pain, muscle pain. But it really is trying to heal the musculoskeletal system without surgery.
Gotcha. So a lot of stuff in that box up until the point where, hey, we need to do an invasive procedure, a fracture, got to put the two ends of the bone together, or, hey, that ligament's torn. You'll see everything up into that part where it's time to operate.
Exactly. There are a lot of primary care sports medicine that will take care of one team, and that's a really cool idea too. I don't personally do that right now, but you are the team doctor for that team, so you also offer primary care for that team. So, for example, the Spurs players, one of them has a cold and needs a doctor. They get in quickly with their primary care sports medicine doctor. But then they also later roll their ankle and have an ankle sprain. Also, you see that doctor for everything. So there's a lot of models with sports medicine, but it's the idea, there's a lot of ideas. It's growing so much as a specialty, but either being a primary care provider for one team or being a non-operative orthopedic doctor.
So you have to have the skill set and the training to understand the athlete himself, the personality, or the patient walking into your office that may have two different needs and two different concerns that want to stay active, and then the training and the skill set to say, is this something I can treat, or do I have to triage this and send it out? So that's a pretty diverse skill set.
Absolutely. I love that you were talking about superheroes and we were talking about teams too. I like to think of the primary care sports medicine doctor as a really integral part of the team, so that if a person needs a ROSTI or physical therapy, we're communicating with those providers. If someone, ruptures their ACL skiing, then they need surgery and go straight to the surgeon, and you kind of manage that with a group of healthcare professionals.
Gotcha. How do we properly utilize? Because I know when we go through school as chiropractors and physical therapists, those are the providers that work at Orthopedic. We're trained to identify and kind of refer patients out to kind of where they need to get to. But one of the things that we aren't trained alongside against is people that have your skill set, your niche, your primary care sports medicine physician. So how do we utilize you effectively to benefit our patients, and how can we help you in terms of when you're sending us somebody our way? So how can we create that synergistic relationship effectively?
I think that communication is key. So if you have someone that you know from your experience is going to get better with your 3 visits, more or less, and you want to work with them first, go for it. If you feel like it's a problem like frozen shoulder or plantar fasciitis that you think needs to be co-managed, then send them my way or your local primary care sports medicine and communicate. Be like, hey doc, I'm sending you, I think this person could do better with co-management. What do you think about an injection or some oral medication first? And I love working together because our patients do better together.
Yeah, I think you hit one of the key things I think we all get frustrated with in the conservative realm. I'm actually glad you brought up that example, the frozen shoulder. I mean, how infinitely complex can that be? Because it could be autoimmune. There's a correlation to diabetes. It has a bunch of rule outs, cervical referral into the shoulder. Is it true, dysfunction, soft tissues that are adhesed? And I think the perfect person, now that I'm thinking about it, to help us with that may not be the orthopedist, because they may not touch the diabetes, right? But that is part of your skill set, how to manage medications so that we can manage blood sugar, get that A1C down, or can we start them on something for an autoimmune variant, or the primary care physician that's trained in health habits. Hey, smoking is correlated. Nutrition is also correlated. So I think you bring a really excellent point for a condition like that requires more than just it's a shoulder issue. It could be a lifestyle issue. It could be a genetic issue with autoimmune disease. I think you hit a really important point on that one here. And I actually appreciate when we bring people like you into the mix. You can only add value to the patient there.
Yeah, and you have to think about it again as a team. I work with 2 excellent orthopedic surgeons, but you have to think of half of their working day is spent in the OR. So their clinic time is really small. So if there are people that I can help and keep off their surgery schedule, it creates a really nice dynamic as I can help people up until they need time of surgery. And just to clarify, in my clinic, I love helping people with other things like diabetes, rheumatological issues. If they have, anxiety or depression related to their pain, that's great to talk with them. it also is a great door to talk and make sure that people have a only primary care only doctor that they're seeing, that they're getting their annuals and their health and preventative medicine as well. So being able to filter to surgeons, urology, physical therapy, primary care, and anything else in between, acupuncture, anything that is going to benefit the patient.
Gotcha. And I think I got a little ahead of myself, but in saying some of that, and I apologize, but it's just nice to have that mindset with also the neuromusculoskeletal background. I think that's kind of where I was going with that.
And seeing the patient as a whole person with all their parts and not just a shoulder.
Yeah, we're an integrated unit, whether we like it one way or another, and
or not.
Nothing is more apparent than the last couple of years where I've had some patients personally that were responding to treatment, all of a sudden run into a brick wall, and you start talking to them, and they realize mentally they're in a bad place, and something changed.
Pain goes hand in hand with anxiety and depression.
Yep.
So you kind of have to address all of it.
Yep. So, favorite sports med experience. That's your niche. That's your baby. You're race director for the San Antonio Rock and Roll, medical director, I should say, assistant medical director for Rock and Roll San Antonio. Team physician for several high schools. What's been your favorite sports med experience as a physician or a participant?
Yeah. So, I have to say, I was thinking about this, that my favorite moments are in the office. A lot of sports medicine doctors will do sideline coverage, and I don't currently do that. I did help with Johnson and Trinity and the Rock and Roll Marathon, but for my own personal health and lifestyle, I love being with my family on the weekends. So anyway, I was thinking, I love being able to walk into an exam room and meet people's needs and know exactly what they need and just help them get better. So I think my most epic ones are like the kid who tears their ACL skiing and they are seen in the emergency room in Breckenridge, Colorado, and then all of a sudden they have no idea what to do, and they get on your schedule on Monday. And so they show up in your office Monday at 10 a.m., and you see them, and you know exactly what's going on and what they need, and you can counsel them through every step of the next process for them. I have to say that's my favorite, and I have a lot of those. Just, it's not one epic moment, but when someone has pain and has done something traumatic and you're able to meet their needs immediately. Or a different example is someone who, we had a patient a couple weeks ago who rolled their ankle really badly and had so much swelling and was leaving, I don't know, for like a 2-month trip to, I want to say it was Europe, and we flew them down the hall into a Rosti, and the amount of swelling that they had and reduction in pain overnight was just incredible for them to get on a plane and leave for 2 months.
Nice.
So it's more of those small moments that make up my practice that bring me joy more than one epic event.
Yeah, and I think like you, it's an amalgamation of small efforts that add up, and you look at the small efforts and then you look at the totality of the picture. You've done a lot of good to help people, but it's not like you're hitting home runs. Use a baseball analogy. You're hitting a bunch of singles and doubles, but those have impact on people's lives.
Absolutely. Sometimes I think, man, maybe I should have gone into life-saving medicine, but I had this thumb pain the other day. It was de Quervain's tenosynovitis, and I ended up injecting myself. It was bad. I had done a Rosti. It hadn't gotten better. And my husband was like, see how debilitating that was and how much of a difference it makes. And I was like, yeah, I forget. I'm not saving lives with strokes or cardiac patients, but movement matters.
Yeah. And then it plays on the psyche, right? Like I've been a back pain patient myself, and you can go into a dark place real quick when it helps you. And then when you get up and you start moving again, it greases the wheels, the mind gets right, and you're like, I do that to help people, and I experience it, and I appreciate that patient's coming in with that even more.
Absolutely.
Do you have a niche area, an area that you like to focus your practice in, a specific demographic or, a type of a patient?
That's a great question. I'm pretty unique even within the realm of primary care sports medicine because, again, the majority of primary care sports medicine docs will do sideline coverage, which I don't right now. I love the everyday athlete. I love teams, but I just love, the 30-year-old who wants to get back and start jogging some more, or the 50-year-old who decides to start doing like routine yoga for low back pain. Like, I just find so much satisfaction in people who decide they want to move. And so that's kind of my niche, and it takes me in all walks of life. I saw an 11-year-old this morning with back pain, and I also saw an 89-year-old this morning with hip pain. And so it just allows me to see everyone, and not, a lot of our athletes are 30 or younger, and 30 to 50 and beyond need help with pain too. So I would say the everyday athlete is my niche, and I also love procedural medicine. So I am big into injections when they're appropriate. We do a lot of hip injections, back injections, for frozen shoulder injections, and being excellent at ultrasound and knowing what you're doing, or also using like an x-ray machine to guarantee perfection when you're doing injections, so that that medicine went into the spot it was intended to treat and that it's going to be successful.
I think there's a lot of misconceptions out there about, from the patient perspective, guided injections, and then anybody can do them. I want to give you the floor here on what's the training for a guided injection. How is the process of training the diagnostic ultrasound to inject, and then the x-ray guided injections? I don't think people understand it's an art, it's a skill, and what's required to be great at it, which we've shared patients that have had some really good success with platelet-rich plasma in the upper portion of the hamstring. So take us through, how did you develop that skill set? What does that skill set entail? Because I think the average person assumes anybody can do those injections. That's not the case to do with skill and accuracy.
Yeah, absolutely. So this is kind of a soapbox tangent, but I think the majority of injections, unless you have a reason not to, you should be doing them with some sort of guidance. You should be seeing where you're going. And I know that anatomically you know where the knee is, but I want to know millimeters make a difference in terms of, are you in or out of the capsule of the knee. So I would say that 90% or more of our injections, unless there's a reason not to use the ultrasound probe or something, should be done with ultrasound or x-ray. You should be a guided image, you know where you're going. It's not only one profession or one skill or one specialty that can learn how to use an ultrasound or x-ray, and I really didn't hone in on those skills till fellowship. There's so much to learn in primary care. You have what we talked about, you have diabetes, you have hypertension, obesity, all of those things that I didn't get a lot of one-on-one time with ultrasound. That wasn't until my sports medicine fellowship. Other specialties that are really big on image-guided injections are PM&R, which is physical medicine and rehabilitation, or interventional radiology will know how to use ultrasound and CT really well. And it's more doctor specific, like how much time they spend training. So it can be hard to know just upon meeting a doctor what their skill level is for that. But I would probably look for one of those three specialties is primary care sports medicine, interventional radiology, or PM&R.
Gotcha. And then is it a special certificate program, or is the fellowship 100 hours dedicated of this? Like, how do they structure it from there?
That's a great question. In our fellowship, we had weekly meetings with ultrasound, and then it was just how much you wanted to practice on your own. And I believe there was a certification at the end of fellowship, but I've forgotten how many hours are the requirements for that. And those are, because again, sports medicine is so new, those are always being shifted and changed. So I don't know what the current regulations are for that. Gotcha.
Doc, have you branched out? I know we've shared a patient that described PRP injections a lot into the orthobiological realm. Is that like a niche area for you as well?
Yeah. We do. I would say that I usually counsel people to start with what's covered by insurance first. I have had some great success with PRP and stem cells. We do offer stem cells here. They're amniotic injections, so not stem cells like from your own fat or bone marrow, but we have them donated from the birthing process. And I would say it depends on the person, and it depends on the injury, and it depends on the severity of the injury. So I like using PRP a lot for tendinitis, like chronic tendon changes in your hamstring, or in like your patella tendon, or like plantar fasciitis. And I tend to use stem cells more for in the joints. I think for both stem cells and PRP that the evidence is really mixed right now on how successful they are, and there aren't a lot of large randomized controlled studies supporting their use. So I think as long as you've counseled a patient and they know the risks and benefits and success outcome, and they're fine doing it, then it's a great option.
Have you seen anecdotally just more people coming in and specifically asking about that niche, or asking about, like, requesting information about that? I know there's large groups out there that are marketing very quite a bit, radio ads, television ads, and I field those questions, and sometimes you got to start by debunking science from science fiction.
Mm-hmm. Absolutely. And again, it is, I think we hear these things on the radio and think, PRP will work for everything. It works for hair. It works for your knee.
If it works for hair, give me some. Put it right in here.
I think you have to be specific about what you use it for. So I have had some people who have tennis elbow, chronic tennis elbow, and PRP has made their pain go away. I've also had a patient who was getting PRP from an outside clinic, and she had end-stage arthritis of her hip, and that PRP wasn't going to change her bone-on-bone arthritis. So again, it depends what you're using it for, and I think, you know, we take a Hippocratic oath as doctors to do no harm, and to be honest with our intent and the successful outcome of it.
Yeah, and I think most of us kind of have an idea viscerally of what the research is, but I think some people have unfortunately, sometimes some alternative motives at heart when they counsel their patients. So I think candidate selection, like you said, getting that right person for the procedure is important with that.
Absolutely.
What's your role? You work with 2 orthopedic surgeons, it looks like. I looked at your website, did a little internet snooping. Mm-hmm. What's your role in terms of how do you fit in a clinic, with the 2 orthopedists? And it sounds like you got some other options as well. What's your role within your clinic structure?
I love, earlier you called me a quarterback, and I was like, oh, that's a really great analogy. I should start using that.
Are you a Kansas City Chiefs fan?
I am. I watched them lose my entire childhood.
You're the Patrick Mahomes of Orthopedic Performance Institute.
Yes, exactly. I sort of joke because I'm a huge like sci-fi nerd, but when the Ghostbusters came out, which I feel like I'm dating myself, I feel like that's an 80s, 90s reference, but there was a gatekeeper. And sometimes I feel like the gatekeeper of OPI, because we get these calls and these people have knee pain, and realistically they can just get on my schedule so much faster, because again, an orthopedic surgeon is spending half their time in the OR, so their clinic is already half the time that mine is. So I can be the gatekeeper for this practice and push people in the right way that they need to. I don't know if push is the right verb, but do they need urology? Do they need neurology? Do they need to go back and talk to their primary care doctor? Can we get them into surgery? If we can we get them into like tomorrow? You know, it just helps filter people where they need to be.
Is there a specific condition? Like my practice, when I used to practice in Illinois, I had a really big niche in endurance athletes. And kind of what I was actually known for was plantar fasciitis, plantar fasciopathy. So it seems to me all the people that didn't respond would end up on my schedule back when I practiced in Chicago. Here at Orthopedic, I'm taking on a personality of being more of a complicated spine patient that needs management, co-management. And it's interesting. I'm one of my certifications is McKenzie trained, and I actually have people seek me out for that. But that's my personality in my practice. I'm taking more spine cases. I see an uptick in that in terms of what's coming my way. Is your practice taking on a personality with specific conditions that have either failed elsewhere, or you're attracting that into your practice with specific conditions?
We really don't, and I love that about I love a lot of things about orthopedic performance, but one of the things that I love is both of our surgeons operate on every joint of the musculoskeletal system, and so I love that we don't have one specific joint, and so I get to see a back pain patient and then turn around and see a shoulder. So I'm not sure that I have a niche, again, more than just like everyday people who need to be seen.
Gotcha. What age ranges? You mentioned the 11, you mentioned the 89. Is that the floor and is that the ceiling, or does it range? Because I know some folks, family medicine is trained for the whole gamut, but usually they cut it at a certain age point.
Yeah, I don't have specific parameters. Technically, I believe within our malpractice, I can see 6 months and up. A lot of times in really, really small kids, it just depends on the injury. So I would say 6 months and up. A lot of times, if it's something serious in a very small child, I'll refer to an even bigger specialist like pediatric
Ortho, yeah.
Yeah, I think my oldest patient just turned 101, so that was
Holy
pretty
cow.
exciting.
Wow.
It just depends. Age is a number. I have a 98-year-old who just had a patella fracture, and she's doing great now. So some people just have longevity. It depends.
I think the honor of my career was treating some of the people that yesterday was D-Day. It was 6/6/2022. Today's 6/7. Is I treated some people that literally were storming the beaches at D-Day, and I was like, "That's the honor of my career."
Wow,
Honor of my
that's
career.
incredible.
Yeah, they were in their 90s at the
Yeah.
time. It was several years back. They'd probably be 101, 102. I think they passed a couple years ago. But the honor of my career, and I was like, "This is the highlight of my career right now." Is working on you, and like,
It's epic. Yeah, absolutely.
and they're like, "You worked in professional sports," and I'm like, "You're an athlete of a different kind, of a different caliber." So,
Mhm.
yeah.
Yep. And that's, again, I keep going back to this phrase, everyday athlete, but that's what I love is someone that was in Vietnam and now has hip pain but can't have surgery. There's just so much to be said for everyday movement too.
Yep. So people want to co-manage, co-treat, kind of utilize your services. Where are they finding you? How's the best way to reach you?
So we have a website, I believe it's orthopedicperformance.com. And actually, we have a marketer, and I texted her before we started. I was like, I don't know our social media contacts. We have a Facebook page. It's under OrthPerf, so ORTHPERF. And we have some Google links as well, and I'll have to put them in like the show notes because I don't personally know them. I'm so sorry.
That's all right.
But our main number is also 210-545-7171, and we generally can get a patient. We always call them back if it's really, really busy. It takes 3 days for a call back, but usually it's same day.
Gotcha. And then folks like me who, hey, I need some help. I need you to set eyes and ears on the case. When we're sending a patient over to you, do you like images, labs? Like what do you need to help, coordinate the care so the patient doesn't feel like there's a gap? Like you're sending it, you don't even know the patient's coming. There's no name, no identification, nothing. How do you like us to help you co-manage so we can move this patient readily along?
Usually when I start working with providers, I appreciate just like a text message or phone call. Like, hey, I have a patient I'm sending your way. This is my concerns. Until we're used to working with each other. I don't necessarily recommend prior imaging because we have x-ray here in our office. So, and we have ultrasound here in our office too. So if you're going to be sending them here, why not have them come to one place instead of multiple places?
Gotcha. And then, can you access the image becomes important. If you go to, you may not have access to this portal or that portal as well.
Absolutely. And then if we do need to order like advanced imaging like MRI, then we can send to a location that works well with patients' insurance and that both providers can easily see the imaging for. Sorry, I think I lost you there for a
Gotcha.
second.
Well, Doc, I want to say thank you for your time. We're going to wrap this up pretty soon. So do you have any thoughts, remarks, or closing statements? Oh, I'm sorry. I'm probably bouncing off a satellite somewhere. Do you have any closing thoughts, remarks, anything you'd like to
No,
share
that's okay.
about your practice, your niche, or just wise words of wisdom to the everyday warrior, the everyday athlete?
I think the biggest things that we've already talked about is communication is key between providers. Um, that we love taking care of the everyday athlete, and that we really are here just to serve our patients.
And I've found that about you too. You're really great about responding to text messages and communicating. And I appreciate the feedback because there are things that the patient's giving you that I may not get. And I appreciate knowing that because it helps me structure a care plan and tinker with it as well. So I appreciate that.
Absolutely. And as far as for the people listening, go out, have fun, do sports.
Sorry, Doc, you're breaking up a little bit.
Athletes. Oh, that's okay. For our athletes, just go out and have fun. Be careful, stretch a lot, and come see us when something hurts.
Yeah, and you're right. There's a big inactivity crisis, and we'd all be remiss if we didn't encourage our people to get out there more, move, and just enjoy life, right?
Absolutely. Well, thank you so much for having me on the show.
Thank you for your time. I appreciate that, and look forward to meeting you in person at some point in time. But this is a good step, putting a face to the name finally. Uh, Thanks, Doc. All right, see you soon. Bye.